Hello everyone and welcome to today's class. So we're going to start in 5 minutes so that people can join in. Okay? guess we can start today's session. So I hope you guys remember that what we were discussing in the last class. I'll give a quick recap. I'll give a quick recap to it. Let me get the laser pointer. Yeah. So we were studying about G protein coupled receptors, and we learned some basics about GPCRs, and we saw what are the major steps involved in GPCR signaling, what is the basic structure and representation of GPCR, and how actually GPCRs work. As I mentioned, GPCRs are predominant type of receptors in our body, indicating that most of the functions which are associated with our body will be directly or indirectly, most likely, be operated by GPCRs. Though this statement is not completely true, but still we can assume depending upon their numbers, varieties, and the categories. Correct. So as I mentioned, one of the most important function which receptor of this particular family, that is GPCRs, perform is helping us have a vision, right? And how we perceive things, how we see things. So in that there's a very key receptor, membrane receptor, which actually help us in our vision. It belongs to the GPCR itself. So first we'll see a brief description about that vision cycle, and then we wanna revisit our representative image so that we get a better understanding of it. Okay, let me get this.
Hi, and welcome to my video series of cell signaling. And in this video, we'll be talking about...
Yeah. So let me share my screen with you guys. Yeah, I hope you guys can see it. So this is a very good way of explaining how we see basically phototransduction and how a GPCR protein is actually performing this function very effectively and very nicely. Okay.
Hi, and welcome to my video series of cell signaling. In this video, we'll be talking about G protein coupled receptor signaling under phototransduction. Now, vision is one of the best spatial senses because that allow us to see the world and how beautiful it is, right? Now let us try to understand what is the molecular mechanism and neurobiological aspect underlying the vision. Now this is our eye. At the back of the eye, there is a screen known as retina. Inside retina, there are several layers of cells, and we get to know about these cells in shortly. Now, among these cells, there is one particular type of cell which is known as rod cells. These rod cells give us sensitivity towards low light vision. There is another version known as cone cell which allow us to see a colored vision. In the rod cell, in the peripheral region of the rod cell, there are pigments known as rhodopsin, which are located in these membrane invaginations known as discs. Now in rhodopsin, there are specific pockets, and in these pockets of the rhodopsin, you can find a molecule known as retinal. To be specific, it is 11-cis retinal. 11-cis retinal is embedded in the deep hydrophobic pocket of this G protein coupled receptor rhodopsin. When light hits this particular rhodopsin molecule, there is a conformational change which leads to conversion of cis retinal to a trans format, a trans retinal. Now this conformational change has consequences, but before that, let me tell you that the retinal is actually derived from beta carotene. Beta carotene is cleaved in specific places in its polyprenoid chain to give rise to all trans retinal, which is the pigment inside the rhodopsin, or which is the phototransducing system inside the rhodopsin. Now, let us look at the signaling transduction mechanism in bit more details. So rhodopsin, as it's a G protein coupled receptor, it's a 7 transmembrane domain coupled receptor, and it has like 7 transmembrane domains. Now rhodopsin is generally coupled with a G protein, a trimeric G protein, which is known as transducin. Transducin has 3 G protein subunits, alpha, beta, and gamma, just like a GS signaling regime. Now when light hits, what happens is few things. First of all, after hitting the light, the external helices of rhodopsin gets tilted. As a result, there is a opening of a site in which the transducin can get interaction. And as a result, what happens is in the transducin, there is a hydrolysis of GDP and there is an exchange of GTP. Now, once in a GTP bound state, transducin is active. The active transducin leave the trimeric state and activate another phosphodiesterase molecule, a particular enzyme which is destined to degrade phosphodiester bond, and it actually converts cyclic guanosine monophosphate into only GMPs. Now, what is the consequence of that, and what type of relation does it have with vision? We'll get to know soon. Now, normally, when there is a dark state or there is absence of light, there are cyclic nucleotide gated channels, which are basically cyclic GMP gated channels. These channels allow sodium influx inside the cell, and that's why the cells were always depolarized. Now, when there is no light, the cells are depolarized. I repeat, when there is no light or in a dark situation, the cells are depolarized state. This might be pretty much awkward for you, but this is the case. We always think, okay, the light would activate the neuron and that would lead the signal transduction. But here, these photoreceptor neurons, they have a different regime. They're always active. They're constitutively active. They're always firing. But when the light hits them, they stop firing. Now, in a moment, it would be very clear. So stay tuned. Now, what happens is when cyclic GMP is actually degraded to only GMP by the action of phosphodiesterase, the level of cyclic GMP falls down. As a result, the cyclic GMP gated channels no more pumping sodium inside the cells, right? Now what happens is the cells become hyperpolarized because there is a constant potassium outflux. So inner side of the cell is becoming more negative. Now what happens is, look at this synapse between a bipolar cell and a photoreceptor cell. When the situation is like dark or there is no light, there is a lot of neurotransmitter release, especially glutamate release in this terminal, and the neuron is constitutively active. It's a depolarized state of these photoreceptor neuron. But whenever there is light, less neurotransmitter is released from the terminal, because now we know, because whenever there is light, there is activity of the cyclic GMP phosphodiesterase and reduced activity of our cyclic nucleotide gated channels, and that's why the neuron cannot be in a depolarized state. The neurons in presence of light is now in a hyperpolarized state. Now, you might be thinking that, okay, in a hyperpolarized state, how does the neuron send the signal to the brain? How it is possible? Now, action potential is just an all or none phenomena. It's a lot similar like binary code. So you might think, okay, in binary, 1 has a value and 0 also has a value, right? Similarly, having action potential means something, and also not having action potential means something as well. So when there is a suppression of the activity in response to light, that leads to a higher order signal in our visual cortex, which is located at the backside of our brain, and that is processed by higher order brain centers, and that's how our visual perception is created in the visual cortex. But how the visual cortex process that signal or decode that signal, that is beyond the discussion of this particular video. Now, one of the most important feature of this pathway is the signal amplification capability. It turns out that one molecule of rhodopsin can at least activate 800 molecules of transducins. Now, one transducin molecule can activate one cyclic GMP phosphodiesterase, but there is a twist. The cyclic GMP phosphodiesterase molecule can at least hydrolyze 6 molecules of cyclic GMP. That means if 800 molecules of cyclic GMP phosphodiesterase was activated by 800 transducin molecule, now there would be 4800 cyclic GMP broken down to GMP. That would lead to massive change in each step, and each step the degree of change is more, and thereby we can understand the signal amplification. Now what happens is there are like several mechanisms which can allow the cell to get back to its firing state or restore its firing state, and one such molecule is beta-arrestin, which would sort of arrest the transducin from interacting with the phosphodiesterase. As a result, cyclic GMP level would be restored and build up. Not only that, in absence of transducin activating phosphodiesterase, there is another molecule known as another protein known as guanylyl cyclase, which would convert GMP to cyclic GMP. Now, all these mechanisms in a combined way would restore the restore level of cyclic GMP. What it would result is influx of sodium from outside to inside. That means the cells would be now depolarized, and that is how after you see something, your neurons stopped firing for that time, and that is perceived in the higher brain or brain center, and after a while all the machinery is ready again to make that neuron constitutively active. So in this video we kind of looked at the mechanism of signal transduction, the neurobiology behind phototransduction, not only that, the regulation of phototransduction at a molecular level. I hope you enjoyed this video. If you like this video, give it a quick thumbs up, and please don't.
Right, so it might seem that it's very hard to follow, but if you know the basics of G protein, as I'm gonna repeat myself again right now, that how G proteins work. So this is a pretty standard way how all the G proteins work. Let me share my presentation again so that we can walk through the signaling pathway one more time. Yeah, so this is the basic mechanism through which we can see. At the end of the day, we are seeing with the help of GPCR. So instead of thinking that you just saw the pathway for how we are perceiving light, try to put all the information of the molecules such as transducin, rhodopsin, sodium channel, cGMP, and all those in this representative figure of G protein coupled receptor pathway, right? So if here the ligand, once it is bound to the G protein, so if we are talking with respect to the vision system, that ligand will be light or photons, correct? And then we are saying it is binding to the receptor. That receptor name is rhodopsin when we are talking for the phototransduction pathway. So when light or photons reaches the rhodopsin molecule, there is structural change associated in the active receptor, that is in rhodopsin, due to which a G protein is activated, right? The G protein gets attached to the rhodopsin. Here the G protein name was transducin molecule, okay? So transducin was actually a G protein which gets to the activated G protein, that is rhodopsin. Once it's there, it leads to the change in the structure of a molecule, correct, from from trans to cis, okay, which further activates an effector molecule, and the effector molecule here it was phosphodiesterase, like which converts CGMP to GMP, right? So it was a standard G protein receptor pathway, correct? Now if we look specifically at the vision cycle, so this is the vision cycle. The easiest way I could have like explained you guys is this is the figure. Other figures are a bit more complicated, but if we look at here, the light comes to the receptor, which is the rhodopsin receptor. It gets the transducin molecule, which further activates the PDE molecule, right, which is inactivated in general when there is no light. When there is light, it gets activated, leading to the conversion of CGMP to GMP. When CGMP molecule is low, why it will be low? Because it is being metabolized by this PDE, which is activated because of the G protein, that is transducin, coming to it and activating it. Okay, when there is low GMP, the channels will be closed, hence neurotransmitter won't be active, correct? But once there is no light, what will happen? These channels will stay open because there will be lot of CGMP and they are CGMP gated channels. So if CGMP is available, the channels will be open, and hence the neurotransmitter or the plasma membrane, it will be in the polarized state. But once it is low CGMP, it will be in hyperpolarized state. Okay, so if you guys want, we can actually take half a session maybe in next class how action potential works, because at the end of the day it is also a membrane phenomena, right? Why? Because all the proteins, that sodium potassium channels and transporters, they lead to the generation of action potential. Hence we can actually cover action potential in the next class by like in the coming Tuesday. Okay, so this is the basic representation of vision cycle, how we see. So you can see how one of the greatest senses which we have is that how we see the world around us. It is guided just by a single structural change in a small molecule, right? So it is marvelous that a conversion of a bond from cis to trans or trans to cis in other pathways leads to the downstream signaling in such a way that we are able to see. So similar mechanism is for the hearing also. Okay, but I'm not gonna discuss that. It is a different mechanism, but the point which I want to mention here is that though the stimulus is less, the beauty of signaling pathways or the signaling is that, see, we had one ligand, right, that is light. We had one protein which was activated. We had another protein which was activated. Then we had small molecules. So if this is 1 1 1, but they are not one, they'll be in hundreds of number, because of which there will be change in the concentration of particular molecules inside the cell. Hence a single ligand magnified its effect once it goes downstream. So this is one of the characteristics of signaling pathway. Though we need lesser ligand to activate the signaling, but the effect is so pronounced that a single ligand won't be able to do it if there was nothing related to the magnification of the signaling entity, right? Light is not being amplified here. It's just the effect of the light is indirectly being converted to chemical energy and then electrochemical gradient and then further neuro synapses, and then we are able to see. So this is the beauty of signals. We need little bit of stimulus, but in the downstream that effect is magnified by the number of secondary messengers. So if for example one PD is activated, it will further generate multiple, in hundreds and hundreds of GMP molecules, right? But not one light. If these mechanisms were not in place, then if only the light was the source of maintaining this particular channel, it will take a lot of time for us to see, right? So this actually happens. If you can relate, you all might have experienced this. So if you go from extremely bright room to a dull room and vice versa, you can actually sense, and there is little bit of lag when you get adjusted to the new light, right? So why this happens? This happens because the molecule whose structure was changed here, right, it needs to take some energy in and get back to its default form. This is one of the reason that we take little bit of time to adjust in a new room, irrespective of whether you are going from bright room to dark room or from dark room to bright room. Okay, so this is the reason why there is little bit of lag in our vision. So this is one of the membrane proteins functions which were seen. There is another function which is associated with membrane protein but not specifically G protein. So now you see, if there is any issue with this particular G protein, right, rhodopsin, they will be hampered vision for us, right, or for anyone who has this particular pathway related to vision. So this pathway is kind of conserved in the eukaryotes. I am not aware of how much it is conserved in lower eukaryotes, because at the end of the day we evolved, right, and hence these molecules are also adapted according to our surrounding. So if, for example, the one way from where the diversity comes in, depending upon our vision range, is the number of rods and cone cells, correct? So if we take about the mouse example, they are nocturnal animals, right? So do they actually need a lot of rod cells to sense color and light? No, right, because they are nocturnal animals. Hence the number of cone cells will be more and they will be more effective. Similarly, if you compare the number of rods and cone between mammals who are like day oriented, diurnal, and to those who are nocturnal, you can actually see that there is difference in the number of rods and cones. So if there are more rod cells, it indicates that you are well adapted or more precisely adapted to see in bright light. For example, if we talk about birds, right, eagle, it is said that eagles have a very great vision. So they have a lot of rod cells which are very well tuned for distinguishing seeing in the bright light, correct? If we talk about nocturnal animals, it will be vice versa, correct? So another membrane protein which is associated in a disease, we're gonna see it right now. So let me share.
I have a doubt.
Sure.
Ma'am, can you tell me that where can we find the study materials of the slides that you taught?
Yeah, I guess, see, I'm having trouble in uploading, as I've mentioned already. So what I'm planning to do now is I'm gonna upload these slides on my YouTube account, okay? And in the description I'll provide the books which I have referred. Till now I am referring from two books only, particularly Lodish and Leninger. These are the standard books. So some of the material I'm taking from cell biology by Lodish, and then biochemistry from Leninger's, okay? When I might upload them on my YouTube channel by tomorrow, so you can get this information in the description itself. And if you want more material,
so ma'am, we will get the slide in the form of video.
I'll upload these lectures and I'll upload the slides also in the Moodle platform. I hope you guys are aware of the Moodle platform.
No ma'am, I am not aware of it.
So this ISSC, sessions, they are uploaded on a server which is called Moodle. So it's a like user interface where you, just like NPTEL lectures, right, you'll have a dedicated place where you can access all the lectures. So I'm going to upload my slides there on the Moodle platform, and you have the access to it already because your email ID has been added to it. Then second, because I'm...
Ma'am, can you do a favor? Can you please share me the link?
Sure,
on email or something?
Yeah, I'll do that. I'm gonna upload YouTube sessions, right? And the moment I will be uploading them, I'll send a mail of my YouTube channel, and then you guys can access it and you can see whenever you want. Also,
okay,
if there are troubles for me in uploading slides on the Moodle platform, I'll mail them to you guys also. Till now I haven't mailed because the course is still undergoing, so that is why I haven't uploaded any slides there. Okay, but if you guys want, I can do that.
Okay ma'am, because sometimes there will be network issues, so we miss some slides or lectures.
No worries. I'll provide all the information. So whatever I am covering in this session, video because I record all these sessions, right? So these sessions will be uploaded on the YouTube. You guys can access from there. The slides will be uploaded on the Moodle platform, but if I'm having some trouble in uploading there, I'll either mail it or I'll attach my slides also in the YouTube description only. I'll provide the Google link for it.
Okay, ma'am.
Yeah, sure. So this particular disease, it is associated with membrane protein itself, but not G protein. Okay, so we are moving past the G protein, which is a part of membrane protein. Now we are seeing other things which are associated with membrane protein, and this particular disease is called cystic fibrosis.
Cystic fibrosis is an inherited disorder characterized by a defective CFTR gene, resulting in impairment of the body's ability to generate normal secretions like mucus and sweat. It's inherited in an autosomal recessive pattern, meaning both parents need to carry a faulty gene for the child to be affected. And it's estimated that around 1 in 25 Caucasian people are such carriers. The condition is life-shortening, with median survival age in the US in 2021 being 33.9 years, and projections for those born between 2018 and 2022 to be 56 years. The CFTR gene is found on chromosome 7, and it codes for the protein CFTR, which stands for cystic fibrosis transmembrane conductance regulator, that forms a cyclic AMP chloride channel that normally allows movement of chloride and bicarbonate across epithelial membranes, and also, by extension, sodium and water. This protein is primarily expressed in the exocrine glands. Those are the glands that release secretions through a duct to an epithelial surface, and over 2,000 defective variants to date have been found in this gene. But around 85% of cases are due to the variant F508 deletion that causes misfolding. The most commonly affected organs include the lungs, pancreas, sinuses, hepatobiliary system, intestines, and sweat glands. Normally, the CFTR channel helps move chloride and bicarbonate out of the cell, causing sodium to remain outside and overall to cause water to move out of the cells, forming normal secretions. The overall result of the variants in the gene, however, is decreased secretion of chloride out of the cells and consequently increased resorption of sodium into the cellular space, which therefore means more water tends to remain in the cell. This translates to thicker mucus on epithelial surfaces and more viscous secretions from exocrine glands, which generally predisposes them to becoming obstructed, leading to pathology. In sweat glands, the role of CFTR is actually reversed. The channel is meant to bring chloride in from the extracellular space to the intracellular space, and so encourage sodium and water to be reabsorbed. It's for this reason that in cystic fibrosis, chloride remains in the sweat, and so does sodium, causing the sweat to be excessively salty, and excess sweating can also lead to significant dehydration. In the lungs, the CFTR dysfunction can mean stickier mucus that is more difficult to clear for the cilia, leading to mucus plugging and a breeding ground for recurrent infections, particularly Staphylococcus aureus early on in life and Pseudomonas aeruginosa, colonizing 60% of adults later on. There is then inflammation with release of proteases and cytokines that perpetuate the lung injury, including release of interleukin-8 that can stimulate further mucus secretion, altogether giving episodic exacerbations and eventually dilatation and destruction of the airways, termed bronchiectasis, with progressively worsening lung function. The resulting hypoxemia can lead to pulmonary hypertension and eventually right-sided heart failure, or cor pulmonale. In contrast to COPD, emphysema is not prominent, and although the respiratory system may be normal at birth, respiratory disease can begin even in infancy. As we mentioned, the pancreas can be affected. The obstructed ducts can lead to early activation of the enzymes and subsequent autodestruction of the pancreas. Pancreatic function then deteriorates, eventually causing insufficiency. The endocrine function of the pancreas is largely maintained, at least initially, but diabetes mellitus is present in 2% of affected children and 50% of adults. Involvement of the intrabiliary ducts leads to bile stasis and eventually hepatic fibrosis in nearly 1/3 of patients, with around 3% progressing to have biliary cirrhosis and portal hypertension by the age of 12. The intestines are also affected, particularly by having more viscous secretions, which can lead to meconium ileus in neonates, where there is an intestinal obstruction in neonates due to the increased viscosity of the meconium, and the viscous fluid may predispose to intestinal obstruction in adults. In males particularly, fertility is greatly impaired, with 98% of male patients being infertile due to poor or no development of the vas deferens, which are ducts that aid sperm transport from the epididymis to the ejaculatory ducts. In females, fertility can be impaired due to the viscous cervical secretions and may also be linked to nutrition deficits that we'll touch on shortly, with 15 to 30% of females estimated to be affected. Symptoms typically begin in infancy or in childhood, manifesting often as a failure to thrive. Respiratory symptoms can include recurrent respiratory tract infections, with coughing and wheezing being common features, as well as disturbed sleep and gagging, often related to the cough. During exacerbations, hemoptysis is more common, and as the disease progresses, shortness of breath or reduced exercise tolerance become more prominent. Pancreatic insufficiency leads to malabsorption of nutrients, particularly fats, resulting in poor growth despite a good appetite. And it can also cause foul-smelling stools laden with lipids that are difficult to flush, called steatorrhea. Malnutrition and vitamin deficiency, particularly in vitamins A, D, E, and K, which are the fat-soluble vitamins, are common. We mentioned meconium ileus, that can present with vomiting, abdominal distension, and failure to pass the meconium, with similar symptoms involving stool and intestinal obstruction in adults. Other systemic features include salty tasting skin or formation of salt crystals on the skin itself, and there can also be excess sweating in response to heat or fever that can predispose to dehydration. A diagnosis is typically made when there is clinical suspicion of cystic fibrosis, for example, a positive newborn screening, an affected sibling, or clinical manifestations, and evidence of dysfunctional CFTR genes. Newborn screening is the way in which most cases are diagnosed, which initially looks for the level of immunoreactive trypsinogen in the blood, taken from a heel prick, followed by sweat testing and CFTR gene analysis. A sweat test can be done as early as 48 hours after birth and involves inducing localized sweating, typically using pilocarpine, and then evaluating the volume of sweat produced and the concentration of chloride in the sweat. Levels below 30 millimoles per litre are considered normal, while those of 60 millimoles or above are considered abnormal. This should then be confirmed with a repeat test or genetic testing identifying 2 disease-causing cystic fibrosis variants. The values between 30 and 59 are considered intermediate, and then if repeats do not suggest cystic fibrosis and 2 disease-causing variants are not found genetically, then it may be a diagnosis of CFTR-related metabolic syndrome. Pancreatic function is evaluated looking at pancreatic elastase in stool, which may involve serial measurements to identify progression to insufficiency. Imaging can involve the use of CT, typically done routinely every 1 to 2 years, but also at times of exacerbations, with findings ranging from hyperinflation and bronchial wall thickening to bronchiectasis. Pulmonary function tests involve spirometry, done routinely 4 times a year in those beyond 5 years of age. There is typically a reduction in forced vital capacity and forced expiratory volume in 1 second, as well as the FEV1 to FVC ratio. While there is no cure, the goal is to alleviate symptoms, prevent complications, and improve the overall quality of life. From a respiratory point of view, this involves vaccines such as the annual influenza and more recently COVID-19 vaccines. Airway clearance measures involves movements to encourage expulsion of the thicker secretions, such as chest physiotherapy, active cycle of breathing, and other methods like vest therapy may also be an option to aid this, and aerobic exercise is also encouraged. This helps increase the
So you saw how a little bit of change in the membrane protein can lead to such disastrous disease, right? This is one of the example. As I've mentioned, due to the frequency and the number of GPCRs, oftenly it is observed that most of the disease have directly or indirectly related to GPCRs only, right? So here I want to broaden your understanding by saying and by remodifying my statement that most of the disease or the drugs which we have, not necessarily all of them, but they are the easiest way is to target the membrane protein at the end of the day, because membrane protein will be the entrance point for any pathogen or information inside the cell. Hence, designing drugs, looking for biomarkers, this is a very demanding field in itself. A lot of computational methods have been developed to actually screen out membrane proteins for which a drug molecule can be designed, which is directly or indirectly be related to a disease, right? So not only GPCRs, as you have seen here, there was another membrane protein which was involved. Similarly, there are other diseases which have shown that there is little bit of alteration or mutation in the membrane protein which leads to the occurrence of the disease itself. Hence, so if you guys have heard it of, there is a tool or an algorithm or say methodology called CAD, that is computer aided drug design. So it basically what it does is, most likely we're gonna discuss this is this part of our last module for our this particular session. So in CAD we actually come up with biomarkers, most preferably surface biomarkers, right? So that you can identify easily, you can target them easily. That is why having a in-depth knowledge about the membrane proteins and how they are functioning. So for example, when we saw for the vision, the rhodopsin molecule was actually inducing a structural change which leads to the activation of a G protein, that is the transducin molecule, right? So if we are able to understand the mechanism through which that particular membrane protein is functioning, we will be able to design better drugs, better molecules, better understand the disease, correct? So before wrapping up the membrane proteins section, I would like you guys to revise one more time that there were 6 major functions of membrane protein, right? The functionality which is involved in the cell membrane is from the proteins, not from the lipid part, right? But it has been observed, and more information is coming now, that lipids actually help in membrane protein functionality. So there are certain proteins which are embedded in the membrane, and lipids are also embedded in them, or they actually reach till the middle of the membrane protein. And if we remove that lipid molecule from that protein is not functional anymore. Hence, having a dense environment in the membrane, having proteins closely associated with each other and with the lipids, it makes a functional unit, correct? So if we understand how these proteins are working, we will be better in designing drugs, helping in understanding the prognosis also. It can also work as markers, it can also work for diagnostic purposes. So all these things can be understood once we understand how a membrane protein is functioning. So right now we saw one of the receptor function of a protein, that was GPCR. GPCRs are basically receptor kind of function they are performing, right? Before that we actually saw the transportation function when we were talking about sodium potassium channel, sodium potassium pump, right? So those were the transportation part of the membrane proteins. And here you can see how the receptor, which is also a part of membrane protein, and how it is regulating a membrane transporter or a channel, right? This was another function. Hence, as we say, there are 6 major functions to membrane proteins. They are not isolated, they are interconnected. So once we discuss action potential in the next class, you guys will actually see how a simple change in the concentration of ions leads to the opening and closing of membrane proteins, which further leads to the transfer of a signal from your extremities. For example, if you touch anything hot, so that hotness is being stimulated, or the source of stimulus is your hand, but you are feeling there, it's because your brain is telling that it is hot at the end of the day, right? So how fast this happens, this we're gonna see how the action potential is generated and how it is transferred from the place of stimulus to the brain, and then from back to brain to the place of stimulus. Okay, and this all happens just because there is a slight change in the ion concentration, which leads to the opening and closing of membrane proteins. Okay, so see you guys in the next class, and thank you for your patience.